Good afternoon, everyone. So Martin and I will be talking about models of care today. I'll briefly discuss models of care, and then Martin will get into what the actual implementation looks like through a case study. So what is a model of care and why is it important? And I'm sure most of you are quite familiar with this. So to put it simply, a model of care broadly defines the way health services are delivered. And most specifically, it outlines best practice care and services for a person, a population, a patient cohort as they progress through stages of a disease or an event. And it is important because a model of care is multifaceted, and it can impact on client health outcomes, service quality, service economics, service accessibility, organization policy, workforce structure, and also sustainability of the model. So, coming to the traditional model of oral health care. So, as most of you will be aware, a range of factors interact to determine a person's oral and general health. And these can be biological, social, political, economical, in addition to the person's knowledge, beliefs, attitudes. However, the traditional models of oral health care that we're quite familiar with have generally ignored the range of factors and have instead focused more on the downstream surgical management of existing pathology. The following sequence of pictures will illustrate disease management in the traditional model of care. So you start with the cavity, you go to the dental practitioner, you get it filled. Sometime later, the filling fails, and the cavity is now bigger. You now go back to the dental practitioner who uses special equipment to do a more complex filling. And again, sometime later, the filling fails, and now you've got a much bigger cavity, which will require more complex restorative procedures. And finally, you end up with this broken system that you just learn to live with. So why does this traditional surgical model of care continue to be dominant in spite of all the advances in disease management? And it's because dentistry is yet to fully embrace evidence-informed practice. Most of you here will be well aware of the decline in caries rates that occurred between the 1970s and early 80s. Well, unfortunately for us dental practitioners, the research showed that we only explained about 3% of that decline. The rest was due to oral health promotion activities, the widespread introduction of water fluoridation, and toothpaste. It was Star Wars Day 2 days ago, so I thought that might be quite apt. Also, recent studies among dentists in New South Wales showed that dentists consider their colleagues' opinion as the highest level of evidence, and we know that that's actually the lowest form. And it's this lack of evidence-based dentistry that has been driving dentistry to date, and the reason for us being quite ineffective in controlling disease. However, in contemporary times, there is advanced understanding of the oral disease process in areas such as diagnosis, lesion incidence, and progression rates, minimally invasive preventive strategies, and the social determinants of health. The Fisher-Owens framework shown here illustrates the multi-level and multifactorial influences on oral health and can be used as a guide for disease management. So in response to this advanced understanding of oral diseases and the critical importance of prevention and oral health promotion to health outcomes, innovative evidence-informed models of care are being developed and tested. However, the challenge here is to put evidence into practice. I'll now hand over to Martin, who will talk you through a case study of the actual implementation. Thank you.
Well, here we are again, and I like the photo. How do we get that off, by the way? Okay. Look, Brad's doing a PhD, and you probably need a PhD to understand what's on the screen. So I'm going to bring it right down to the client level and the clinic level, and I'm going to discuss a case. It's Mr. Nguyen. He's a 45-year-old widower with 2 teenage children. His English skills are okay, but he's more comfortable in his first language. He's unemployed, a smoker, he has missing teeth, and he hasn't seen a dentist for a few years, and last time he came there was an extraction. Now, I'm going to run through Mr. Nguyen's experience with us and stop at points of perhaps difference with other clinics. So in the beginning, he comes in as an emergency client. We have the same, there's no difference between how we manage emergencies than any other clinic. So he would come in and Dr. Jessica would do the examination and restore a tooth. But during that process, she suspects he might be high risk. And at that point, we would offer him a follow-up appointment, a general course of care, starting with an assessment. As he's of Vietnamese-speaking origin, we would select oral health therapist from the Vietnamese-speaking community to take on his case. So on the day Mr. Nguyen would turn up, he would be greeted by a Vietnamese-speaking receptionist who would take give him his medical history form in a translated Vietnamese form and ask him to sit in a very comfortable, welcome area. Some of you have been to our clinic and know that it's actually quite a luxurious clinic, all modern, and we use the terminology welcome area rather than waiting area. You can figure that one out. And he's watching oral health information on the TV screen. In a while, usually a short while, out comes Caitlin, our Vietnamese-speaking dental assistant, Certificate 3. She will take Mr. Nguyen into a non-clinical consulting room, and at this point she would have a conversational interview. Now the point of that interview is to establish a relationship with the client in a non-clinical setting. She would try and elicit information like his current oral health behaviours, a bit about his history, and maybe a little bit about his level of health literacy. But most importantly, she will try and find out what his expectations of his episode of treatment with us would be. Now, Mr. Nguyen, all he wants is some dentures to fill up the gaps. And so that information that usually takes about 5 to 10 minutes. Meanwhile, another DA is in the clinic room with Tan doing the changeover of the previous client. Now, Caitlin will escort Mr. Nguyen into the clinic, and it's a normal clinic, there's nothing different about it. And where there's a full examination will take place, there'll be charting, radiographs, etc. But also there will be both a caries and periodontal risk established via a modified Canberra caries risk assessment tool and using CPI, Community Periodontal Index. If there's time, there would be an OPG and a full perio chart done. Mr. Nguyen is both caries and perio high risk, with multiple active caries, lesions, generalised 5+ millimetre pockets, and several missing teeth in the anterior region. Some of the contributing factors might be poor oral hygiene, keriogenic diet, possibly saliva factors, and a suspicion of diabetes. Tan also thinks he has low health literacy. So that's another point of difference. Caries risk assessments and periodontal risk assessments are done. Now, at the same appointment, a preliminary management plan will be discussed, which includes a mandatory 30-minute session with Lulu, who is our oral health educator, Certificate 4 trained by DHSV and RMIT. Tobacco cessation will be offered but is refused. And at this point, his 2 teenage sons would be invited to come to an appointment for assessment. Again, that's a point of difference. We don't try and separate families, and we don't put people onto waiting lists who don't need to be there. Or we don't think need to be there. Lulu and Mr. Nguyen meet some days later in a room which is shared with the podiatrist in another part of the building, not near the dental clinic. And this visit is conducted in English. And together, they will establish realistic goals towards improved self-management. Another point of difference, it's a shared management process rather than a top-down. Now, during the first visit, Lulu won't be trying to do too much, but we'll be testing saliva quality and quantity, plaque scores, and she might discuss diet and oral health instruction. Oh, right. Oh, geez. Lulu prefers on-site websites and can demonstrate and uses. Oh, God, you rattled me now. Hang on. Lulu prefers an online website with lots of demonstrations rather than and images rather than too much words. The critical point of this is to establish relationship, and the emphasis on factors will be determined by what happened during the handover with Tan from the original assessment. His social determinants will be taken into consideration, his level of education, his level of poverty, and home situation will be used along with motivational interviewing, goal setting, and health coaching techniques to improve his health literacy. It may take several follow-up appointments for Lulu to be satisfied that he is actually self-managing well. Because of his high perio, Lulu will conduct a diabetes assessment questionnaire, and if appropriate will be referred to the diabetes nurse next door. Mr. Nguyen does well and is referred back to the clinic. First visit is to Vang, our Vietnamese hygienist, for a scale and clean, then back to Jessica and Caitlin for restorative care, and finally to Scott for his partial denture. Now, Mr. Nguyen starts off quite reluctant to see Lulu as he just wants his teeth fixed and something for the gaps. Partway through Lulu's appointments, however, he gets angry. Why haven't I been told about how to look after my teeth before, as I would have more teeth? He's actually very grateful and wants the rest of his family to spend time with Lulu. He's also reconsidering tobacco cessation program and has agreed to see Alison for our oral health. Alison, who's our oral health therapist who's done the respiratory health training at Alfred Hospital. And he also may have spent some time with the diabetes educator and dietitian, because it was discovered he was pre-diabetic. Lulu has a great relationship with Mr. Nguyen, as most of the team does. He feels at home and safe, tells us more about himself. He trusts us to help him, as it was about working together, not a top-down victim-blaming approach. Dr. Jessica can do beautiful restorations in a clean mouth, and which is easy to work on, and several active lesions are now looking like they're going to rest and no longer require restoration. Scott's remarks on how clean Mr. Nguyen's mouth is, and he feels he would easily apply self-management techniques to his dentures. Scott refers back to Tan, who had by this time has managed Mr. Nguyen's sons, who are going okay. She completes the episode of care by conducting another conversational interview and a clinical risk status reassessed. She then decides if Mr. Nguyen is put on a recall or is discharged as low risk. So does it work? We're talking about evidence-based dentistry, and we can't prove anything. Intuitively, I think you'd all agree that that's a much better approach to dental care than what Brad was saying before about the roads. And our waiting list is full of low-risk clients, and we can prove that because 90% of them are coming through, having an exam, and are still classified as low risk. And for those that value the economics, we haven't gone broke. However, we do need money to do a proper evaluation. Okay, some of the things that might help you along, we have DWAR system, and we have standards where 800 DWARs for a dentist is their target, 600 for a oral health therapist, and we're doing about 400 DWARs for our oral health educator. So you can play with those figures, but you can charge through at the same rate whether an oral health educator is doing the numbering or a dentist and a nurse. But you can obviously see there's cost differentials there. So what next in our model of care? Integration, and watch this space. So that sort of covers that, and this is Brad and his evaluation plan. I won't go through this, but you'll probably be on the website. And something from Nelson Mandela, thank you. That's it.